A very good evening to one and all. Wish you a very, very happy new year. On behalf of Neurocritical Care Society of India, I welcome you to the first journal club of this year. So, today we'll be discussing a very important topic, which is the utility of procalcitonin in bacterial infection. So, the article is from Critical Care Medicine. It will be presented by Dr. Shama Rao. Shama is presently doing her neurocritical care fellowship at St. John's Medical College. Over to you, Shama.
Thank you, ma'am. Good evening, everyone. Today's journal club I'll be presenting an article on diagnostic accuracy of procalcitonin in bacterial infections of the CNS, an updated systematic review, meta-analysis, and meta-regression. This article was published in the Journal of Society of Care Medicine newly in January 2024. Coming to the introduction, bacterial meningitis, ventriculitis, and cerebritis are severe life-threatening infections that may be community-acquired or occur after neurosurgery, TBI, or shunt device positioning. Due to the high rates of morbidity and mortality associated with it, early diagnosis, prompt and appropriate treatment are of paramount importance. In critically ill patients suffering from acute brain injury, signs and symptoms of bacterial infections of the CNS are non-specific and often overlapping with signs and symptoms of underlying neurological conditions. Hence, in these cases, commonly used CSF parameters such as leukocytes, proteins, and lactates may be of limited value since eventual presence of blood in the CSF, like in SAH and TBI, and metabolic derangements due to inadequate oxygen supply may alter CSF lactates and protein concentration. Furthermore, the overlapping with other forms of infections, such as aspiration pneumonitis, VAP, and systemic sepsis, and related antibiotic treatments, may delay a prompt diagnosis and the initiation of appropriate treatment. So, what is procalcitonin? Procalcitonin is a protein produced by C cells of the thyroid gland and secreted in the blood. Serum procal levels increase markedly in patients suffering from bacterial infections, and it is being proved to be an accurate and reliable biomarker in patients with sepsis or pneumonia. Calcitonin mRNA has been isolated from hamster brain cells, which suggests the possibility that procal may be locally produced by CNS in response to inflammation. Thus, many studies have been investigating the roles and diagnostic accuracy of serum or CSF procal in bacterial meningitis. So, what is procal role in sepsis? When the antigen of the bacteria is present in the body, there's activation of the complement and fibrinolytic pathway, causing neutrophil activation and release of proteases. Also, it stimulates the macrophages to produce TNF, interleukin 1 to 1, 6, and 8, which worsens the tissue damage. This tissue damage increases the secretion of procalcitonin, and this procalcitonin is used as a biomarker of systemic sepsis. In their systematic review and meta-analysis, Wei et al. Have found that both CSF and serum procal are effective diagnostic markers for bacterial infections of the CNS, both community-acquired and nosocomial, concluding that additional well-designed studies still needed to corroborate their results. Since then, further studies have been published focusing on roles and diagnostic accuracy of serum or CSF procal in CNS bacterial infections, some of them proving that CSF procalcitonin gains higher diagnostic accuracy. So the aim of this systematic review and meta-analysis was to ascertain the diagnostic value of serum and CSF procalcitonin in CNS bacterial infection in the light of most recently published evidence. So the methods employed in this study was conducted in accordance with the PRISMA statement recommendations and registered under Prospero. The studies indexed in PubMed, Cochrane, and International Web of Science databases between January 2016 and September 2022 were deemed eligible for study inclusions. The search strategy employed for this study used keywords such as procalcitonin, CSF, meningitis, and CNS infections. Two investigators independently screened and assessed titles and abstracts and identified studies potentially suitable for this systematic review. If eligibility could not be ascertained from the title or the abstract, the full text of the study was retrieved, and those deemed suitable were reviewed for eligibility according to the study's characteristics and the clinical relevance. And the reference list of recovered articles were then scrutinized for any additional suitable articles, and any conflicts were addressed by a third investigator. The inclusion criteria for this study were peer-reviewed original research articles of RCT and observational studies, either prospective or retrospective, reporting evidence on the clinical relevance of procalcitonin sampling in patients with CNS infections. CSF microbiological cultures as the reference standard with no age limit, including adults and children alike, and availability of full text publications in English language. However, animal experiments, reviews, correspondences, case series, case reports, expert opinions, and editorials were excluded from the study. Data extraction and quality assessment. The extracted data were as follows, which included publication details, including author, year of publication, details of the study population, including age range and number of patients, and interventions carried out, including in procalcitonin assay results and the diagnostic cutoff points. The true positive, false positives, false negative, and true negative rates were also reported being calculated according to the CNS bacterial infections and non-CNS, non-bacterial infections, and non-infection sample size based on the reported sensitivity and specificity of each study. The selected full articles were critically appraised and quality assessed using the revised quality assessment for studies of diagnostic accuracy tool. So how was the data synthesized and analyzed? The data for diagnostic sensitivity and specificity of Procal were pooled using two random effect models, either the bivariate model or the hierarchical summary ROC model as appropriate. The bivariate model exerts paired sensitivity and specificity as the starting point of analysis and represented a more reliable indicator of diagnostic accuracy of an indexed test in a meta-analysis when compared with the traditional ROC approach. So the random effect models with or without covariates were fitted using logistic regression, and the model adjusted pooled absolute and relative diagnostic accuracy are presented graphically in forests and ROC plots. So in meta-regression, the 12 statistics are not calculated, and heterosity has been assessed on logistic regression expressed as tau square. As appropriate, either hierarchy summary ROC or the bivariate models was used to assess the threshold effect and determine whether the degree of threshold variability in included studies was a significant source of between study heterogeneity that could have affected meta-analysis accuracy. So in the presence of a high tau square value, a certain degree of between study heterogeneity is confirmed. Then visual inspection of SROC curve allowed to confirm if a threshold effect is the plausible cause of observed between study heterogeneity. Then, if most study points are in approximity to ROC and or confidence region largely encompasses ROC, a threshold effect is plausible. And if the aforementioned conditions do not occur, the threshold effect is unlikely, and different other factors may account for observed in-between study heterogeneity. A Fagan plot was created showing relationships between pre-prescribed prior probability, likelihood ratio, and posterior test possibility. Deek's test was used to test for potential publication bias, and all analyses were performed using Stata-Corps, and a p-value of less than 0.05 was considered statistically significant. So coming to the results of this study, the initially identification of the literature was done, and 5,347 articles were carried out, of which 4,023 articles were removed as duplicates. Further, a number of articles were excluded from the study after reviewing the titles and abstract and removing the reports which had irrelevant data or not retrievable data. And then further exclusion was done following clinical studies, wrong outcomes, and abstract only. So finally, 23 articles were used for this review and meta-analysis. The study demographics of this study are as follows. A total of 3,766 critically ill patients were included in the analysis, among which 2,614 were children and neonates, which is 69% of the population, and 801 adults, which is 21%, whereas 351 patients were a group of a mixed population, including both children who are older than 5 years of age and adults. Study characteristics. To evaluate the accuracy of procalcitonin for diagnosing CNS bacterial infection, 5 studies focused on CSF Procal, 11 studies only on serum Procal, and 7 studies focused both on CSF and serum Procals. 6 studies enrolled post-neurosurgery patients, of which 2 studies focused on external ventricular drain infections in children and adults. 12 studies enrolled pediatric patients. 2 studies included neonates, and 10 studies recruited adult patients. Diagnostic criteria for bacterial CNS infections were varied, hence, overall study quality was low. This is a table summarizing the diagnostic accuracy of CSF and serum Procal. As seen here, the both the sensitivity and specificity of the CSF Procal was much higher when compared to that of serum Procal. Also, what is to be noted that the cutoff points was much narrower for CSF Procal between 0.33 to 0.72, and when compared to the serum Procal, which was between 0.16 to 8.72. So the range of cutoff for serum was much higher, making it less accurate. Also, what is striking in this table is the fact that the sensitivity and specificity for CSF Procal was much higher compared to that of serum Procal in post neurosurgical infections and EBD patients. Also, it is significant in the pediatric population. And the likelihood ratio, positive likelihood ratio of CSF was much higher than that of serum Procal. Then, coming to the CSF Procal and serum in adults, as seen here, the CSF sensitivity and specificity Procal with in a patient with CNS infection is much higher when compared to that of serum Procal in the same patients. So the forest plot of pooled sensitivity and specificity of studies focusing on adult patients showing possible threshold effects for CSF PCT, and an even higher in between study heterogeneity for serum PCT attributable to different factors other than threshold variability. And in similar picture is seen in children and in post neurosurgical patients. However, these findings are more glaring since the difference in the specificity and sensitivity and specificity in between CSF and serum is more jarring. This shows a funnel plot in a patient comparing the CSF and serum Procal to rule out the likelihood of bias. Here, when a line is drawn depicting the regression line, the studies are plotted here according to the p-value of coefficient of the slope. Here, as seen in the CSF, it is more close to the regression line, where as compared to the serum, in the serum it's more sporadically placed and wider apart. So CSF looks to be better than a serum Procal assay. However, what is to be noted is that the p-value of CSF is 0.55 and that for serum is 0.22. Since both of them are less than 0.05, they are not found to be statistically significant, and hence data is found to be symmetrical with low likelihood of publication bias. This diagram tells us the probability ratio or the likelihood ratio. Here in the CSF Procal, the post-test probability ratio comes to around 71%, while that of serum comes to be around 66%. However, the post-test negative likelihood ratio is 4 for CSF and 5 for serum. So what does this basically indicate? It means that the patient who has CSF bacterial infection is more likely to have a positive result with a CSF sample than with the serum sample. And both of a patient who does not have a CNS bacterial infection will have a similar picture in both CSF and serum sample. As in, it helps to pick up CSF procalcitonin helps to pick up a true positive patient, whereas CSF and serum are both equally good in ruling out a CNS bacterial infection. Coming to the discussion, the meta-analysis of all included studies showed that CSF Procal was associated with just a slightly higher pool sensitivity and specificity when compared with serum Procal. This finding was confirmed by hierarchical summary ROC analysis, which indicated that the area under the curve for CSF Procal was slightly higher than that for serum Procal. The pooled positive likelihood ratio was found to be 7.3 for CSF Procal and 5.8 for serum Procal, indicating that the patients with confirmed CNS bacterial infections had a 1.5 fold higher chance of high CSF Procal compared with serum Procal. On the other hand, there was no significant difference in the pooled negative likelihood ratio being found to be 0.14 for serum Procal and zero point 0.15 for CSF Procal and 0.15 for serum Procal. The Fagan nomogram confirmed a slightly higher positive predictive value for CSF Procal compared with serum Procal and a similar low negative predictive value. The probability of CNS bacterial infection was 71% for patients with the tested positive for CSF Procal and 66% for those tested positive for serum Procal. On the other hand, CSF procalcitonin level lowered the probability of the disease to be as low as 4% when negative and compared to 5% of negative serum procalcitonin. These results confirm that a positive CSF procalcitonin has a higher pooled positive likelihood ratio compared with the serum procal. The subgroup meta-analysis based on age showed that pooled sensitivity and specificity of elevated CSF procal was even higher when compared with serum procal, especially in children, and slightly higher in adults. These findings were also confirmed by ROC, indicating that area under curve for CSF procalcitonin was higher than those for serum procal, particularly among studies on children. Furthermore, CSF Procal gains highest pooled sensitivity and specificity for diagnosing CNS bacterial infection as compared with the serum Procal in those cohorts of critically ill patients after craniotomy or EVD positioning. So far, what we have deciphered is CSF Procal is more superior when compared to a serum Procal assay, especially in post-surgical patients. However, when CSF Procal assay is not possible in some institutions, serum Procal is of equal importance. Utility of Procal in post-surgical serum Procal in post-surgical or EBD patients is as follows. Regarding, as discussed previously, regarding following acute brain injury, who develop CNS bacterial infection after craniotomy or EVD positioning, serum procalcitonin alone may not be enough or accurate to confirm CNS bacterial infection due to the overlapping condition with eventual other forms of infection such as aspiration pneumonia, VAPS and sepsis and related antibiotic treatments. And signs and symptoms of CNS infections are non-specific, often overlapping with signs and symptoms of other underlying neurological conditions. And commonly used CSF parameters, as discussed previously, like CSF lactates, may be of limited value since the presence of blood in the CSF and metabolic derangements due to inadequate oxygen supply occurring during acute brain injury may alter CSF lactates and protein concentration. In a previously done study by Schutz et al., they had found that a drop in the serum procalcitonin level of at least 80% was associated with survival outcome and further supports the approach of serial monitoring of procalcitonin level. And serum concentration of procalcitonin may help discriminate invasive bacterial meningitis, and their related dynamic changes could assist in withholding antibiotics. The cutoffs. The cutoffs of this study, this meta-analysis showed a diagnostic cutoff point for CSF procalcitonin ranging between 0.33 to 0.72 for CSF. However, well-defined trials are required to ascertain the findings of this meta-analysis. Strengths of this particular study are as follows. This study included 7 studies focusing on neurosurgical patients, and the use of 2 random effect models, which are bivariate and HROC, considered the most significantly statistically rigorous methodologies for pooling diagnostic tests. Accuracy showed to appropriately estimate between study heterogeneity and to assess threshold effect. The Deeks test suggested a low likelihood of publication bias of studies included in the meta-analysis. However, the limitations of this study are as follows. The limitations are related to the inconsistency of thresholds in eligibility studies, which may be due to various procal assays used. No studies assess the loss of integrity of the blood-brain barrier in neurosurgical patients, which may overestimate the accuracy of CSF procal. Furthermore, one of the main limitations in this study is represented by the fact that this meta-analysis was aimed at comparing just CSF procal to serum procal, whose diagnostic accuracy was not compared with the commonly used CSF parameters such as leukocytes, glucose, proteins, and lactates. Further meta-analysis is needed to compare standard CSF markers to CSF and serum procalcitonin. To summarize, this meta-analysis showed that CSF procalcitonin gains higher sensitivity and much higher specificity for confirming CNS bacterial infections, especially in children and after neurosurgery and or EVD positioning, when serum procalcitonin alone may not be accurate enough. Overall, CSF procalcitonin appears to have a higher pooled positive likelihood ratio compared with serum procal. In conclusion, additional well defined studies are required to address between study and within study heterogeneity and assess optimal diagnostic threshold for CSF and serum procalcitonin for diagnosing CNS bacterial infections. Thank you.
Thank you, Shama. Thank you for that extensive presentation. So, based on this study, so will it affect your clinical practice? Any take homes from this particular study which you will be able to use in your day to day practice?
Based on this meta-analysis, it is noted that a CSF procalcitonin assay is superior, especially in children and in post-surgical patients, and with patients with the CNS bacterial infection post-EVD placement. So, in our institute, we would like to send CSF samples over serum samples in this in this set of patients.
Okay, so what do you think is the main limitations when you go with CSF procalcitonin compared to serum procalcitonin?
In the patients with the disrupted blood-brain barrier, we do not know if the uh, source of the procalcitonin is this CNS per se or due to underlying overlapping systemic sepsis.
Okay, and
So,
this, yeah, please proceed.
we will not be able to probably distinguish with one value. A serial monitoring would be advisable.
Yeah, exactly. So, though this meta-analysis gives a cutoff for different population and different subset, like in EVD and children and adult, the serial trend is what is more important. And is there any other utility of procalcitonin, especially CSF procal, when you are working up for meningitis? So one place it has utility is it can help differentiate between bacterial and viral
Viral, yes.
meningitis. And that is also an important dogma we face in the neurocritical care unit. And one highlight about this methodology, especially, so very well presented because it had a little bit of complicated statistics. So the usually a receiver operating curve is what is used where you directly report your sensitivity and specificity for a particular diagnostic test, but that is not really possible in this case because you had mentioned, so each study which was included in the meta-analysis had different cutoff values. Okay, and some studies reported serum, some studies reported CSF, and some studies reported both. So to kind of get a cutoff value you need to use advanced statistics. So for this, just a few words about bivariate model and the hierarchical receiving summary receiving operating curve. So bivariate model is usually used when you have to see a correlation between sensitivity and specificity, and this is especially useful when you have to give a pooled estimate. Suppose multiple studies are giving different values and you have to come up with one pooled estimate of sensitivity specificity. This is very very useful. And the second method used in this journal in this study was the HRROC. So that is something unique because HRROC is used when there is a lot of heterogeneity between the studies. Like in this case, you have adults, you have pediatrics, and you had serum, you had CSF. So in a way, HROC gives us a relationship between sensitivity and specificity across different threshold. So this is especially useful when there is a lot of heterogeneity. So that's why they applied both the models, and based on visually inspecting which model is more relevant, they kind of arrived at the sensitivity, specificity, and the cutoffs. So that was what was something different in this study and in this meta-analysis. So to summarize, Shama, if you have to summarize the whole journal club and what is your learning in a sentence or two? Can you please summarize the journal club?
Um, to summarize, although the both serum and CSF have equally good sensitivity and specificity, it is noted that the CSF procal levels are a little better when compared to serum. When unavailable, serum is equally good. Also, one value wouldn't be sufficient. A serial monitoring would also help us to prognosticate the patient, help in either escalating or de-escalating the antibiotic therapy, and helps to differentiate between viral and bacterial meningitis in especially in post-surgical and pediatric population.
Correct. And in post surgical, also, there is a confounder of surgery. When you have in post surgical patients, again, that also can affect your procal levels, right? So, trauma. So, that's the challenge in neurocritical care unit, where CSF probably that's the reason why it had slightly a more advantage over serum in this special subgroup of patients. Okay. Thank you, Shama. Thank you for that wonderful presentation. On behalf of NCSI, we look forward to having you in many more forums. Wish you all a very happy new year and thank you.
Thank you, ma'am.